This is the recorded lecture on the critical care and emergency nurses. We kind of talked about some of the scenarios on the other day, so I just want to record the lecture, and then I'll be, give you an opportunity to listen and read. And then I'll answer any questions that you may have when we return to class. However, these are our learning objectives. We want to be able to describe the knowledge acquisition used in critical care settings, and then also identify the preparation the nurses may need to provide the care to those clients requiring critical care, and also look at some of the legal aspects of emergency nursing, then look at our roles and responsibilities when caring for those clients experiencing traumatic or emergent injuries, and also we will be able to apply the nursing process through the use of clinical judgment function while using the triage system when caring for those clients involved in like mass casualty or disasters and things of that sort. So as we look at critical care nursing, it is critically important that we have those critical care competencies that we can build on a solid foundation of fundamentals. We have to have that solid foundation going back to fundamental skills, and also which include but not limited to the nursing process, which y'all hear me talk about a lot, and we've started utilizing that clinical judgment model, which I think it's a great assets. I'm sorry. Also, managing situations, being able to make decisions, teamwork, and collaboration is critically important. Again, also I say clinical judgment, making that sound clinical judgment decision based on recognizing cues and collecting that data, and then also looking at interventions and implementing those interventions, and also being an advocate for the client, and then we have to teach our clients. Then also caring for clients, diverse. We don't know working in critical care, particularly the emergency department, you don't know what population of patients or clients you're going to be caring for. However, again, our goal as interprofessional or team members, we'll make sure that we're looking for those good quality outcomes for our clients, and we want them to improve by providing that interdisciplinary care. We need everybody on that team, even down to pharmacy, dietitian. So this is like in the circle here. We want to be able to mobilize a ventilated client. Again, we have to have that team approach. And also there is a tool, we talked about that daily rounding tool, the ABCDEF tool, and basically the acronyms we kind of talked about in class. We need to assess our clients, prevent and manage pain, make sure that they're breathing spontaneously, and also doing the SAT trial period for those clients that are on the ventilator. Also, making sure that we give the clients accurate anesthesia, again, based on our physician's orders, our healthcare provider orders, or sedation, and then monitoring and assessing those clients after we medicate or sedate. Then assessing for delirium. We want to assess and prevent it because we know that some medication may cause the client to have delirium, and then we need to also assess for it and then manage those clients accordingly. And then early mobility. We want to get those clients up, get them mobilized as soon as possible to help decrease any further complication. And also family engagement. We talked about too having the family involved in the client's care. Sometimes it helps that client to recover more quickly. Also, we talked about the rapid response in the code blue. And as I said the other day, usually facilities they may have different codes, but however, we need to be we need to know what those codes are. And I did say that sometimes facilities may give you a little badge with those codes on there as for a quick reference. So code, rapid response code when it's called. Again, that's usually when the client is deteriorating, having some respiratory alteration, maybe cardiac, blood pressure may be dropping, they may be going into hypervolemic shock or blood pressure, any alteration, changing their mental status and a hypoxemia. Usually a code is called or when that client is deteriorating. And then a code blue, usually, like I said, called when the client is in full cardiac arrest. And like I said, it just depends on the facility, on what code that they use. But most I've known was blue for a client that's in full cardiac arrest. Um, Also, as far as the running the code, we kind of talked about that. You will play, you could play many roles, different roles. You may be that nurse to give medicine. You may be that person to do compression, help with the start of the code, documentation, somebody to record. You're gonna have a respiratory therapy support team on your respiratory therapy on your team. So again, everybody has a role, and I kind of mentioned in class the other day that nurse that does the documentation, he or she must make sure that you document accurately. You're not gonna may not have time to document in the healthcare records electronically, but usually it's transcribed from your notes on a clipboard or something. Then it's put into the computer because the code happens so fast. You may not be you're not gonna be able to do it as fast enough in the computer. So good note taking is very important. And then you want to document as soon as possible in the client's record. Okay. We talked about the crash cart. We as nurses we need to be maintained. Um, Nurses must maintain the life support skills and also equipment use in cold blue situation, meaning that you need to know what the equipments are, what's all on the crash cart, and then again we have to check that crash cart every 24 hours, and we replenish it after the code. And I mentioned too, if that the seal has been broken on that crash cart, it may or may not have been used in the situation, but only you know that. Somebody, the oncoming staff or nurses may not know that. So it's always important that we replenish that cart, or even if like the little tab is broken, we need to take it down to Central Supply, wherever your policy say, and get it rechecked and then resealed. Okay. We check the function of the defibrillator. We turn it on and make sure it's working. Make sure it's plugged up, the battery. Make sure there's paper in the defibrillator in the machine. Also, make sure, like I said, the supplies are there. Medication, if like I said, if the card has been broken, the seal has been broken. Somebody may have just used some medication out there. However, IV supplies. So again, document whoever checks that the card needs to sign off the date and time it was checked. Whatever nurse. And usually on you're gonna be assigned to maybe crash cart. So everybody has an assignment to that you're gonna be assigned to do on your shift. Preparation to provide care again. One way that clients enter to the ED, into the critical care path, is usually through the ED. And so we must have the knowledge and skills to provide emergent, urgent, or non-emergency care. Our skills are very important. We have to be our assessment skills should be up to par. Triage and communication is a big key. You triage those clients, we triage them and treat them according to the severity of their illness or injury. And a lot of times clients may come and say, I was next in line, but there should be a sign posted in the emergency department stating that clients will be seen based on the severity of their illness or injury. So a client may have to wait if it's a non-life threatening situation. Describe the action that you can take to prepare yourself for the role of critical care nurse. Just kind of think about that and meditate on it. We kind of talked about that the other day. One thing for sure, you need to make sure your skills are up to par. Then again, there are also some, make sure you have to be ACLS certified. And also there's a critical care or emergency department certification that you can be certified in too, taking that certification in critical care. As a part of our assessment, again, we assess those clients. We're looking at the vital signs. We have to look at the chief complaint, any history of any present illness. And then, based on our assessment and client complaint, we do a focus assessment. We do not do a head-to-toe assessment when a client presents to the emergency. We focus on the problem at hand. Okay. Now, at some point, and we kind of talked about that too. Those clients that may be involved in an MVA, you want to do a focus assessment, but at some point, we need to fully assess that client, particularly because sometimes you clients may have some injuries on the backside that you may not be you can't see. So getting the clothes off these clients, undressing them. Sometimes you have to cut their clothes off them. Working in critical care, you need to always have some trauma scissors because clients come in traumatized with jeans on or clothes that you can't get off of, and then you don't want to tug on the client too much either, trying to undress them. So I had to cut off a plenty clothes. And again, so just keep that in mind. Also, when we assess, doing an assessment of disaster, we look at primary survey, secondary, and also to tertiary. We kind of hit on that the other day too. So primary survey, you're going to use your ABCDE assessment. You're going to assess those clients, like I said, looking at the primary problem that brought them to the emergency department. Okay. Okay. So again, when we triage, I kind of mentioned this earlier, we prioritize that client immediately, and then we provide care based on the client, the severity of their illness or injury. So again, you may have multiple clients to come in, but we have to look at those clients, and there are three tiers: emergent, urgent, and delayed. And again, delayed is something we kind of talked about. It may be like a toothache, something minor, maybe a slight burn, something to the hand. Then you have emergent and urgent care. Of course, based on the severity index here, resuscitation, we know that client that requires resuscitation is going to be emergent. And then high risk clients, we're going to look at those clients that may be needing two or more resources, one resource or no resources. That's going to be like a delayed. And then one resource also, they may just need some lab values. Somebody may come in for no resources needed, may have to come in for some suture removal. So that would be a delayed person that's delayed. And then urgent would be those clients that may need two or more resources. So again, looking at the client severity of injury using that emergency index. Also, so we kind of went over this little activity here in class also. So based on the scenario here, what's the priority setting that you would use to triage this client? You're gonna again that A B C D E, and of course it's going to be that client with that stridor because that's going to be airway. Okay, so we need to go ahead and hand off reports. We talked about that SBAR, how critical important it is that we do the SBAR. Communication is critical. We have to pass on that pertinent information to the nurse that you're giving a report on. Always good documentation and only that pertinent information that's needed in your handoff reports. So documentation is going to be critical. Legal aspect, like I said, nurses, we all have to be aware and abide by any internal or external regulation that guide practices. Again, emergency medical trauma treatment and active labor act umbrella. We kind of talked about that. We have to treat clients regardless of their ability to pay. Okay. Also, we when we the client present to the ED, we have to stabilize those clients. And I kind of mentioned the other day, may be a burn patient. So if it's a burn patient that's severe and there's not a burn center in your facility, we have to stabilize that client before we just ship them to another facility. Meaning make sure to get them as stable as possible. IV started using your sterile burn pack kit and keep getting the pain under control again until they can get to a burn unit. So stabilization and providing care, regardless of the ability to pay, falls under the MTELA Act. We know that there are violence in the emergency department. It could be nurses as the victim or also nursing caring for the client. Sometimes um, family members may get upset with the nurses or the staff. You're not doing enough. So again, I've seen, nurses almost being attacked in the ED, and that's where most EDs now are locked. So you just can't walk in. You have to come in with security. But back when the ED was like an open, anybody could walk in. So now this is the reason for we have security because the family members were attacking the staff. I've known staff family members to get around the bed when you're trying to do a code and you have to call security. So to alleviate that, that's why you have see a lot of patrolling in the emergency department. Also, again, you have to make sure you refer to your state nurse practice act. Also, and then knowing your roles and responsibilities as an RN and what you can and cannot delegate to an unlicensed person or a licensed person like the LPN. So knowing your scope of practice. And I kind of talked about the MTELA Act, the Emergency Medical Treatment, any preventing refusing care to the client, uninsured client. Like I said, it falls up under the MTELA Act because any hospital could risk of losing their Medicare funding if violation occurs. If it's noted and could be verified, they could lose funding from Medicare. Also, nurses, the impact of COVID on MTELA also now allows for the ability to send patients to an alternative location for required medical screening. So again, hospitals were overwhelmed with COVID, so it was kind of like a lift for them. They give them a little more leeway to send patients to a different facility for screening. So it permits the transfer of clients who are not totally stable because the hospital was overwhelmed. So they kind of gave them a little cushion. Um, We know that the ED is a highly risk area for violence. We kind of talked about that for the staff, the family, and visitors. So some contributing factors could be due to the situation, the emergency situation. Family members could be under stress. They could be anxious. They could be under the influence of drugs or alcohol. It could be mental illness, long wait times. Like I said, they get upset if it's a long wait time. And then also they're kind of anxious and fearful of the diagnosis or the outcome. And then crowded waiting rooms. Again, sometimes the client get family visitors get frustrated, they take it out on anybody in the waiting room. I was sitting here, things of that nature. So just be mindful of that. Also, I used to see we see a lot of rape victims come into the ER. That's violence in nursing. Okay, again, we have to evaluate clients who have been experienced that sexual assault. Back when we did the rape kits, but now um, anyone that does a rape kit, they must have must be specialized in sexual assault, examine a nurse. And so now, what I'm saying that there's what we call a SANE nurse, a sexual assault nurse examiner, should be the one that you would assign, should be assigned to a victim of rape, because that nurse, that same nurse, has been trained how to correctly collect those rape kits, do those rape kits, because a lot of cases were thrown out of court because the kits were not collected correctly. Also, that nurse been provided the skills and training to provide emotional support to the victim. Also, not only do the rape kit, but also to evaluate any injuries, any bruises, any cuts, any scratches, and also carry out the forensic exam. Collecting the evidence is critically important. Using that sexual assault evidence kit, it's called the rape kit. That rape kit used to be housed in the emergency department. From what I understand now, when you there's a rape victim in, then the rape kit is brought in from by the local authorities. However, wherever the rape kit is, wherever you get it from, if the seal is broken on that kit, it's sealed up when you get it. If that kit is contaminated in any way, you do not need to use it because it could cause, contamination of the evidence. Also, when you do the kit, the rape kit, there's a chain of command form, meaning that if you're doing the rape kit as a SANE nurse, you're going to seal the kit correctly, put that kid in like a sealed another envelope, and there's going to be a chain of custody form. So you're going to be the one to sign off. That's the starting person you on that chain of custody form. You're going to sign your name on that form saying that you were with the specimen at all times. That means any specimens, anything that you collect, meaning that you didn't get your eyes off it. It was totally under your care and your eyesight, and you sealed it up. And when you sealed it up, if the authority is not there to get it, there should be a safe in the hospital that you can lock it up in the safe. And usually you'll get the supervisor involved. He or she will come and lock it up in the safe if the authority is not there, the police are not there to collect it, to take it with them rather, or the forensic person. However, you sign off on it, then whoever you give the to gonna sign off that they got it and that it was not the seal had not been tampered with. Okay, that's how the chain of command form needs to go with that kit. So again, it's critically important that you sign off on it, and if you're the one to receive it as a supervisor, you're gonna make sure that the kit has not been tampered with before you put your hands on it. So then you would take, as a supervisor, you would take it to the safe or give it whomever gonna give it to the authorities, because if it's been tampered with, the authorities do not need to take it. Okay. Also, communication, we kind of talked about that. That communication, there's the ATI communicator exercise and ATI, but also it kind of walk you through the modules in class. We're not gonna do that, but however, it teaches us how to de-escalate a situation, tactic used to de-escalate a situation, and also it kind of tells us about what can escalate a situation, though, how to escalate the client displaying aggressive behavior. So again, we try to talk the client down. Don't ever approach a client that you feel like is going to be very aggressive that could attack you. You always want to make sure you have security on hand, or if you're going to have to restrain somebody, you definitely need some backup. Okay. So this is basically applying the nursing process. We're going to apply the clinical judgment model. We're going to recognize cues, analyze the data that you collected, prioritize your hypotheses. Going to prioritize your care. You're going to do, implement the care, and then also you're going to take actions. I'm sorry, you got to take action. I apologize, and then you're going to evaluate did whatever you put in place, did it work? So this is a function of the clinical judgment model. So again, you're going to apply that process through the clinical judgment function. We have to prepare ahead for any disaster response, meaning that if we get a call saying that a chemical plant has spilled and we are expecting so many clients by ambulance. Now, just keep in mind, we have what we call a walking wounded. The ambulance may call, so we got 5 clients we're going to transport, but then you may have some victims come in by car. You have not given an account for those. So anytime you want to always double what you they said 10, you're always going to look for 20. You want to make sure you have enough resources. Okay, so you want to prepare ahead. You're going to use the triage system for caring for those clients, and again, at the end of the day, like I said, effective communication. Disaster preparedness, again, we have some bad weather approaching us now. So a lot of shelters are being opened up, and this is when there's a disaster that may come into the ER too, on the ER. So it's going to impact the ER if a disaster hits, whether it's a hurricane, tornado, or fire, or whatever the case may be, a chemical plant may explode. So again, it increased the demand for health services, meaning that you're going to need more resources. May have to call in some nurses. Nurses may not be able to go home. Sometimes that disaster may interrupt communication. You may not have any, the system may go down in the facility. Also, supplies, you're going to use more supplies. So we have to prepare ahead. Also, as far as hazardous vulnerability analysis, there's a tool that we can use. Also, Joint Commission requires that we utilize a tool to assess our vulnerability, to help us with the vulnerability analysis. How likely is your facility or community is going to be affected by a disaster? Like I said, how likely? And again, like I said, depending on if you living in an area where there's like a coal mine or chemical plant. So we look at all those things, and then what is the proximity of the potential hazard? How far? How is it in the neighborhood? Is it in the community? Close, to how much? How close is it to it? What are the past emergencies that have occurred at your facility or community, and how do we handle those emergencies? Sometimes, again, looking at the emergencies, looking at the past, we predict and we plan ahead for the future based on our past responses of what went right, what went wrong kind of situation. Then every facility is required to have an emergency operational plan. We have to prepare, we have to respond, recover, we have to mitigate. Again, so we go through that. What did we do right? Plan and prepare. Like I said, there's an emergency preparedness plan at each facility. So you need to know, you're not going to know verbatim what it says, but you need to know where it is and kind of familiarize yourself with the plan. Again, these are some other questions like how likely is the school community is going to be impacted by the disaster? And then what is the school's proximity to the disaster, potential disaster? Then again, like I said, what are the past emergencies that have impacted the community where the school is located? And I know in Selma, a couple of years ago, tornado came and it went through several schools, so it did impact that community uh, very dramatically. Okay, so again, how we look at okay, we had so many schools, so we need to prepare in any event of an emergency or disaster. How many students, and there's a plan, a community plan also tells us how many industries are in the area and how many schools. So it kind of gives the hospitals also an opportunity to plan ahead, looking at those areas, those communities that could be impacted. And then this is a disaster triage plan. Again, can the client walk? So we use that same acronym: spontaneous breathing, and then functional airway. So we kind of use that same algorithm that we talked about early on. Okay. Then again, communication. We when we triage those clients that's in a disaster, we go ahead and label them. There are tags that we use, and of course, immediate, delayed, minor, and deceased. We don't use any resources on a deceased client. If you know a client has been trapped, say, by a car, and then you can't get that car off that client, there's no way you can get that car off that client. So it's sad to say, but you don't use any resources. You go on to the next client because most likely that client is not going to survive. So you don't use any resources, meaning that you utilize your resources like IV fluids or bandage or whatever the case on the client that has um, the possibility of survival. Okay, so that's how you want to triage. So if I'm out there working a disaster and whoever that triage nurse has tagged somebody as minor, then again I'm going to you're gonna look at those clients that are in severe need. Then this is another case study. You are a nurse working in the local emergency department. You receive notice that there has been a gas explosion at a local warehouse. Five people will be arriving by ambulance. Like I just said earlier, it may be five coming by ambulance, but you may have some that's coming by car. So again, you kind of look at um, that client. Number one, we see here this is a burn client with 40% of the body burn appear while moderate edema, no blisters and soft dry scar. Pain of 9 out of 10. Burn to burn areas, throat is dry, and respiration are normal. Then you go on down a client with shorter breath, respiratory rate 36, face blackened with soot, eyes red, coughing up black mucus, voice is hoarse, respiratory distress as a result of the smoke inhalation. Then a client with a severed leg bleeding profusely, lethargic, skin pale, cool and clammy, first degree burns on the side of the neck, skin bright red, tender to touch, no blisters or eschar. Client report pain 4 out of 10. Then a client with multiple abrasions to the face. So of course, that client number two is going to be um, the first client that you would see. Okay, so that's how we're going to. You are a member of the local disaster response team. There's been a plane crash, and you are tasked with using the color tag system to communicate the status of the following clients to the emergency responders. So you're going to be using the color code tag. So again, we're gonna hopefully we'll get a chance to do this activity in class. So you'll go down and look at whether the client is requires immediate um, care, minor, delayed, so forth. So we'll kind of go over that in class, okay? Now, because I would like to hear from you guys. And then the same thing with the clinical judgment question as well. So I'm going to ask that you go ahead and look at the scenarios. And like I said, on Wednesday, we'll go through those scenarios again, and I'll be able to answer any question that you may have. So I advise you to kind of look at um, that those little exercises. Alrighty, that kind of ends this the lecture. Like I said, it's more like an in-class exercise that I would like to do with you guys, and please read over it, and then we'll go ahead and discuss it more in details, and I'll be able to answer any question that you may have.